So we're going to get started now, and thank you very much, Dr. Dick, for your time today. Documentation to reflect accurate patient acuity and disposition status. We have kind of made it a focus for the ED for this presentation.
I'm moving in.
Okay, come on in. Okay, come on in. And so we've taken out, things that probably don't have anything to do with you after the patient's admitted, okay? So we try to keep it very focused on that ED documentation, okay? And this is a little different than evaluation management, your billing, documentation, but it does help support that. So we'll talk about that more as we go through it. So the role of the ED physician's documentation in providing the thought process and consistently providing that clinical thought in that documentation and that communication with the UR. This is one of the objectives that we have. And your communication with the UR, case management, and with the attending of what you find, and so we can get to that correct status. And then what we have in the documentation. So we want to accurately and completely support that why, the why of that medical necessity. And the ED physician builds that first story, that presentation, and that helps support the rest of the story later. And we use your documentation definitely for coding. We code from the ED for even when they become inpatient. We use those for clinical indicators to support that medical necessity. So sometimes we do have some missing pieces, and we'll talk about some of the things that we find that we may be missing. We want to make sure that that determination has the appropriate patient status is there and that the patient is in the right place from the very beginning. We want to get it right. And then we have some key documentation concepts, which helps us in determining that documentation language. We know physicians sometimes talk in clinical language and they describe, and we want you to, but we also need the documentation of diagnostic that we can code from, okay? So sometimes there's the gap, and that's why sometimes we have to query. The nurses come in, the clinical team come in, and just to help that disparity between the clinical language and that coding language that we may need to show that acuity of that patient. And using uncertain and unconfirmed conditions, even in the emergency room, even though you are outpatient and your coding will be for E&M level for your, and billing is for those certain conditions. So if the patient comes in with abdominal pain, that's going to be the code that you put, but that likely suspected probable in your differential is going to be important too, to even bill for a higher E&M level. So that is still supporting what you've done with that patient. So we still encourage it even in ED in your documentation, and we'll talk about that more. So the goal for us is to provide documentation which accurately and completely represents the complexity of the patient and determine the patient's status in observation or for inpatient. So let's talk about patient disposition options. So we have 4 basic disposition choices. We have treat and release, so they're just treated in ED and then we send them home. Outpatient in the bed, so we can treat them in ED, but still we're waiting on that one last piece of documentation or, lab or MRI, CAT scan result, and then we can release them. Sometimes they are not appropriate for observation at that time. And so that communication with that attending is like, we're just waiting on this piece. We should keep this patient in ED because we have rules by CMS that they really should not, they don't meet observation, they don't meet inpatient. We're waiting on that last little piece. So please interrupt me if you have any feedback or whatever you're seeing too, okay? Observation status, we have that. That is the status. And then admission, we can admit them to inpatient. But that initial patient disposition and decision should be based solely on that clinical need at the time. We want to get it right at the beginning. important. It really doesn't look good of us going back and forth. It doesn't mean that we have it. It means that we don't have it very solid of our decision when we make them obs and we make them inpatient and we turn them back to observation. It tells CMS that we really don't have a solid thought at the beginning of the patient's stay. So, observation versus inpatient, and this is where I know you don't decide the status, but you do communicate it to the physician of what you're seeing, the attending, or what you're seeing, and then they decide on the status. So we want to go over some of those thoughts and some of those rules. So that 2 midnight rule provides that following for the requirements for the inpatient admission. We have to have an inpatient order from the provider. So we have to have that. And then documentation in their notes that that patient probably will stay greater than 2 midnights. So even in you discussing it with the attending, as you see the patient's presentation, what your thoughts are. This patient probably will need greater than a 2 midnight stay. And then that's the first determination. And then is the medical necessity there to support that admission too, based on the patient's comorbid conditions, how they look on their presentation, their age, all of that discussed within that ED record, too, of your thoughts. So CMS is very clear that the determination of the status can only be made by the provider. So it's not interqual, it's not the case manager, we're not going by the case manager's protocol. We're using that, the provider's thoughts. And so you're relaying that thought to the attending of what you're seeing too. So that's why it's so important to have what you're seeing. Because later on, if we don't think that that's there, then we will query that attending for additional information of what you saw in the ED too, okay? So that inpatient encounter of greater than 2 midnights, less than 2 midnights are a target for auditors. They may look at that and let's say the patient didn't stay longer, but if we have that support that initially we thought that they were off, but they just improved quicker based on that presentation, we have that support there. So ED recommendations are and documentation is very important. So this is our patient status matrix. If we're expecting less than 2 midnights by the physician, provider, then an admission, greater than 2 midnights, an admission should occur. Less than 2 midnights, then OBS, and then let's see, and then we may change the status later on. So if you expect the patient's episode of care to extend over to medically necessary, and that's the key, medically necessary midnights, then admit the patient to inpatient. If you're uncertain that they're going to stay less, and it's going to be less than 2 midnights, then maybe observation is appropriate. But after the first midnight, and this is what we tell the attendings too, then maybe inpatient should be considered if they have stayed longer. This is what we give to the attendings. So CMS guidelines for the 2 midnight rule and the impact for that status and level of care. Sometimes they don't stay greater than 2 midnights. It's because of they died or they left AMA or they transferred to hospice. But showing that initial presentation is important, especially with our transfer patients, that something occurred to make them think that they should have been inpatient, but because of unforeseen circumstances, such as they died sooner than we thought, or they transferred, they decided to make them comfort care, then we don't have a greater than 2 midnight stay. Observation status. When we still need, even when they go to observation, it is still a set of rules for observation. Inpatients should not go to OBS, and patients who should not even, they should be treated and sent home, they shouldn't go to observation too. So we still need the why in those services. Why are we going to admit them to, or place them? We don't like to use admit. We're using services, place them in observation. So the why should be there, and that expectation is less than 2 midnights should be there too, that their stay will be less than 2 midnights. So all of that should be there for even observation patients. Inpatient, and we don't have to belabor that, but we need the Y for sure for physician certification of that Y and that medical necessity for that greater than 2 midnight. And this is where our clinical documentation program, when we don't have that support, we will be querying the attendings for that information of the Y. Why of how the expected length of stay, if we're seeing that story that you have told for the ED in that presentation and we're seeing more than what should be an observation, and we see a documentation that's like the diagnosis has not been named but it was described, then we would query for those conditions. And that's where we're bringing in this clinical documentation program into the outpatient setting. So to support that. The physician certification, and this is for inpatient, we have to have an order. We have to have that Y for sure. And then those diagnostic tests, the treatment plan, the abnormal labs, what are we suspecting, the thought process, and that's where that documentation, we support it from that ED, that presentation. What you're suspecting, likely, possible, probable, those differentials. Even though you may not, may be reluctant to name it, you can still use it in your differentials when you document. I'm sure you do. I haven't read the documentation yet, but they are inpatient CDI, and they use your documentation right now to build a query for the inpatient side. But we're bringing them into the outpatient now and into the observation because we know there's opportunity there to maybe support an inpatient admission. Okay?
I know recently the ED physician's documentation has gotten beefed up a lot. I mean, from when I first started 5 years ago to now, there's a lot more meat in, and maybe it's because you're not writing anymore. What were you using before?
The T-sheets.
Okay,
Circling things, yeah.
And now they're using that, well, obviously Epic.
Yeah, so that helps a lot. So we don't have a special sheet for certifications, and Medicare doesn't require us to have that. We can have that documentation located anywhere, the physician notes, admitting diagnoses, orders, diagnostic workups, like the diagnostic workup in the ED, the nursing assessment in the emergency department. How did that patient look? Case management notes. So we just need that story. And ED is so important because it sets the stage for the story. And we always look back and see how did the patient look on presentation, because that's when the status is decided. The initial status is decided at point of entry. So medical necessity, the documentation needed for reasonable clinical indicators are defined by the standard of care and provider's clinical judgment. So we do use at Interqual those standards of care. That's what Interqual and Milliman are used for, but ultimately it's still the provider's clinical judgment that we're looking at and that documentation. So how severe were the presenting signs and symptoms, those abnormal findings that you're seeing when the patient comes in, those abnormal diagnostic studies and your thoughts, this is likely or possible, probable, or sometimes you have a confirmed condition that you're looking at, okay? And it's okay to go ahead and, we need that documentation. Treatment, diagnostics required to determine and manage that patient's care, and that predictability. So we were just talking about the TIMI scores. I don't know what scoring you use for some of your chest pain patients. I know that there's a lot of different scorings, for looking at risk adjustments for those kind of patients. Some clients, I know, use that TIMI score to look at the risk of those kind of chest pain patients. Just discussing that can help us, not using a scoring, but actually saying, they have a family history of this, and they have a history of CAD, a cabbage, and they've had a past MI. I'm concerned for. You're concerned for that. We need that documentation of your concern and your thoughts. So we're thinking ink, and we know sometimes that you're ordering things because you're thinking that way, but we have to have the documentation in order to capture it and support
From
it.
my understanding on CMS, there are some things which are inferred by it. You don't have to specifically state it in the documentation, but a person comes in with substernal crushing chest pain that radiates into the shoulder, and their troponin is 0.5. I don't have to go through and document that to say I'm concerned about acute coronary syndrome because the document speaks for itself.
No. CMS, we as coder, in the coding world, the coder can't make inferences. And in order for it to get that
So
condition,
what CMS can in review. Correct?
in review, they look at what was captured. And what that medical decision of that physician, after he looked at all those abnormal, what did he define that as? What did he name that? And so they don't make inferences too. So if you don't give a diagnosis.
No, I mean, my diagnosis is going to be non-STEMI.
Yes.
I didn't make no mention of my concern that this is coronary disease. This patient's father has this. That doesn't matter because I've already reached my diagnosis conclusion by my positive test.
Yes.
Yeah.
Yeah. And if you reach your positive conclusion and you give us a diagnosis, then that's great, you know. But we can't assume that that's what it is,
Right.
Unless you have a confirmed or suspected, your differential or whatever, you know, because we see some that, you know, they come in crushing and you're thinking it's musculoskeletal, you know, and it's a young patient, has no history, no. So what is it, you know? So we can't infer that that could be a non-STEMI.
Right.
So it should be suspected, possible, probable, and now this one should be worked up a little bit longer, so that supports that medical necessity. Sometimes you can name it, but this is definitely a MI, and it's clear, you know.
I got it.
But yes, that description is very helpful in supporting. We still need all of that description, the family history. That supports your E&M too of what you've done, but we also need the diagnosis.
Mm-hmm.
The suspected diagnosis, your differential, or a confirmed diagnosis to actually capture it and show what was done. Mm-hmm. So, and then the potential risk. Now, that is often what we're also missing, too. What is the risk for that patient? Because that will determine the patient's status, too. If this patient is high risk for being, you know, that something adverse is going to occur, maybe that inpatient status, and it's going to take more than 2 midnights to care for them and work them up, then this should be an inpatient. You know, so explaining those risks involved for that particular patient. You know, I just looked at a chart that they had. This patient came in, he was 20-year-old, had no family history of any kind of cardiac disease, but he was complaining about chest pain. This is his second time coming in the ED, but he had lifted weights, and the doctor thought it was a musculoskeletal issue. They worked him up. All the troponins were negative, but they put him in observation for a little bit. They didn't need they were waiting on that one more troponin to be negative. We could have waited in ED and then discharged because his risks were not, there was no risk there. He had no family history. So the status can be determined based on what you're seeing, too. So, and making sure that we're in the correct status, okay? So, documentation concepts. So, these are some things that we see that are sometimes, you know, there's a language, your clinical language, and then that's coding language, and we come in to kind of fill that gap in. So these are some concepts that we see that sometimes are not clear. We need to support that medical necessity and that patient's determination, and that's the benefit that we see for that accurate documentation. It definitely reduces denials because when an inpatient or even observation status is denied, that physician's E&M can be denied. So the status is important for even what they're coding for their professional billing, you know. So reduce requirements for peer-to-peer discussions with the health plans. When we're sending in things that aren't complete to the health plan and they're saying, yes, you know, we need an inpatient stay, and they're like, no, he doesn't meet for inpatient. We need observation because we don't have complete documentation to support our thoughts, what we're seeing for that patient. And they're just basically going off of what's on the documentation. They don't see the patient. We are seeing that patient. So accurate quality measures too, our rankings of our hospital and the physician, and when we're reporting inaccuracies, is usually in the documentation that we see that when our profiles are inaccurate, it's the documentation. Because we take good care of the patient. And when it's inaccurate, we're like, no, we do a good job here. It's usually the documentation that's deficient that we're seeing. So here is an example, this patient is really sick and it needs inpatient care. Inadequate documentation, because we're just going off of that one piece of paper, and that's what outside agencies, even health plans that we're sending these clinicals to are saying, no, doesn't meet, you don't, the patient's healthy, does not meet medical necessity. So then the results are inappropriate, DRG maybe, inappropriate outcome, the patient has adverse, outcome, and we can't explain it because they were in the wrong status, wrong DRG, he shouldn't have died, he should have done better than this, and that's where those inaccuracies, and it's totally in our documentation. So we want the clinical documentation that historically physicians describe the patient, but we miss the naming of their description, and that's that diagnostic statement that we have to have. We want the description to support your diagnosis, but also we're missing the diagnosis. And the coders cannot make inferences. They can't. Those are rules that we are set up. Yes, we know that high sodium is hypernatremia, but they can't make an inference that you're saying the sodium is high is hypernatremia, even though it's a comorbid condition for that patient that you're concerned about, and maybe explaining their, altered mental status, but we can't capture that condition. And so that's where we have clinical documentation nurses come in and say, there's a gap. We have a high sodium, is the physician, his thought is this hypernatremia. He's giving, so of how they're treating. So our clinical versus coding language. We definitely know that this is a concept that gap is there, and that's why clinical documentation programs are across the nation, and we bring them in to fill in that gap. Suspect, probable, likely, concern for, need to rule out are definitely needed to be used more, and we really encourage that. In your differential, we know that you bill for certain diagnoses, but your differential helps support your evaluation management level. Because when the patient's sicker, you're going to have to work them up longer when they have all of this differential. It could be based on the lab, the abnormal lab, the patient's past medical history. And then specificity, that acuity of those conditions are very important. So suspect, probable, likely, concern for, need to rule out. These are definitely terms that we need to use. In the outpatient setting, unknown conditions cannot be coded, but should be. So we won't pick up a likely, possible, probable in that billing in the outpatient setting, AED setting. Only those confirmed diagnoses will be coded. However, they will support your medical decision in your differential. That likely, possible, probable will support that evaluation management. But in the inpatient setting, it can be coded if it's still suspected at discharge, and it's included in the discharge summary. So there's a difference, but we really encourage physicians to use it across the continuum, even in their physician office setting, likely, possible, probable. Even though they can't bill for those conditions, it's still going to support their evaluation and management of that patient. So specificity, we said that specificity is another documentation concept. So that etiology or that suspected etiology of that sign and symptom. What is that chest pain due to? Patient has a history of CAD? Is this likely unstable angina? Is the chest pain likely unstable angina? I'm starting, a nitro drip and all of these things. So what are you thinking it could be? The acuity, is it acute systolic heart failure? Likely, I'm going to give some Lasix, in the ED. Patient has a past medical of CHF, but I'm giving this Lasix for a reason, because I'm suspecting this is his heart failure, and that it's an acute heart failure. Cause and effect for AKI, the patient had an overdose, now they're in AKI, maybe it's due to the drugs he took, and this is an APN. Now 8 hours into the stay, we have given fluids, and his creatinine is still really high, and we're going nowhere with this AKI. He's not improving. Maybe this could be an ATN for this patient. Manifestations, acute respiratory failure in our COPD patients. They come in acute respiratory failure, and they may resolve before they even leave the ED. So we definitely need that resolution. If they have resolved, then say, he came in acute respiratory failure. But now that we've given steroids, this and that, treatments, back-to-back treatments, this respiratory failure has resolved. And so we can support, even though it's resolved, we are still expecting this patient to be monitored closer in an inpatient setting. And the types, just building the story that maybe the pneumonia is, aspiration, or they failed outpatient treatment, and where they came from the nursing facility, that it is not just a simple pneumonia, and that we can definitely look back on the records of how the patient presented, where they came from. All of that information is there for us to make that decision for that condition. So these are some examples of some gaps that we see in the documentation when you're describing clinical terminology. So dyspnea, respiratory rate 32, using accessory muscles, ABGs. The patient looks acidotic. He's hypoxic, on 100% non-rebreather. He has a history of COPD. Now, we've clinically described the patient, but we haven't named the condition. And so the coders can pick up some of those conditions. They can code dyspnea. They can code, history of COPD, but they can't make an inference that is acute respiratory failure. So they would be guessing, and that is not allowed for us to guess at what your thought is about that. All we would walk away is that patient's dyspnea, the respiratory rate is 32, and it won't show that severity of illness for that patient. And we have some other examples here, the EKG changes. We're going to start some Coumadin. We're going to start amiodarone. Maybe, we need that condition stated of what we're doing and why. So ED documentation, I finally got to the ED documentation considerations after all of that. Documentation included in the ambulance report. So pulling in that thought of how the ambulance report, even that information, sometimes we don't see that, and your thought about what the ambulance saw, and a diagnosis based on that, or your description based on what the ambulance, especially those that are being transferred in, those patients being transferred in, what did the previous hospital see? Because we can't go back into those records and pull out that information. It's the physician who is determining what's important from that transfer facility that will be brought into this state. So that's very important to pull that information at the beginning too. Nursing home transfer notes, if the conditions aren't pulled in, then we can't go back into their notes and get those conditions. So the cubitus ulcers and being very specific, that specificity of location, especially for present on admission issues, for HACs and the hospital-acquired conditions, the POA status is very important. We need to know those things. And we look at the nurses' notes even in the ED and make sure that they are looking at those kind of conditions and making sure that they are evaluating and documenting those appropriately too. Secondary diagnoses that are present on admission, those comorbid conditions of that patient are very important there. And even obvious comorbid conditions that, you know, you're like, yeah, duh, that's there, but we actually need it really stated at that time so we can capture it, that it occurred in the ED. He had it in the ED. It occurred starting in the ED, and it was noted by the physician in the ED. So your assessment is so important for us to support that story. How often do you all look back on your...
Every day.
Yes.
That's where we start.
That's where we start our review of the record.
Yeah, and we'll even, if the physician in the ED hasn't documented acute respiratory failure, we'll pull all that information in and say, hey, attending, can you please give us a diagnosis based on what the ED saw, and then we'll sometimes get acute respiratory failure later on because of the ED docs. Now, again, like I said, I've noticed a lot more sepsis, a lot more respiratory failure in the ED, CHF exacerbation. We've had beefed up records, definitely, and I've seen the differential diagnosis in the medical decision making. And
most of that's because they have to get pulled in an ICD code for, I can put it as my symptom, just, you know, give me an ICD code listed so I can click that, and so that's why it will be specific to that.
Okay, and that's all used in what we do.
So it's important that, so we definitely use your documentation to set the stage of support for that status and for other comorbid conditions that we may query for later on in the patient's stay and building that story. So we know we need from you the patients presenting complaints and that clinical findings that you see, those comorbid conditions, your treatment course. Why are you giving that med? What are you doing? Why are you ordering that test? What are you suspecting? You know, often, sometimes we find that, you know, when I review records from other clients, we don't know why they're deciding to do that MRI, or what are you thinking about doing a Doppler, you know, what are you suspecting? So thinking of what your thoughts and getting it down. And those abnormal clinical findings that you see, you know, elevated troponins, the elevated creatinine, just minor things, maybe their liver enzymes are elevated, just explaining any of those abnormals that occur when they come in. And then, you know, your admitting diagnosis can be, you know, your differential, suspect, possible, and often they may just be their abdominal pain. That's okay, too. But if we had those differentials of what you're thinking is a good thing, yeah. And then working with case management, we definitely know that they are using Milliman, and they're using those appropriate clinical standards, those nationally accepted standards. However, it's still the clinical judgment of the physician and providers that get the patient in the right status. So when we don't have that clinical judgment documentation, we have to only rely on those standards. And you guys know more than those standards of that patient. So clinical judgment of the provider may supersede those criteria and those guidelines. So that's the biggest takeaway from that, is that those clinical judgment of the provider may supersede that criteria. The diagnostic story, when we have the stage set by the ED physician, then we're able to tell that diagnostic story more accurately, because now we're going to decide on if the patient is an inpatient, we're able to give them the correct principal diagnosis. Often ending, you know, they may have had calf pain at the beginning of the stay, but, you know, after the dust settles, now we discover they have you know, you didn't work them up then. Yeah, they were complaining about pain in their calf. But later on, 3 days later, we do a Doppler and they discover DVT. But we understand in the ED that physicians saw that they were complaining about calf pain, they were complaining about this, that, and the other. But we got that documentation, we're able to capture that later on. So that diagnostic story is more complete for the POA status, et cetera. So present on admission, again, I was ahead of myself. That status is very important for those hospital-acquired conditions. We don't want to take credit for anything, that baggage that patient brings in the door with them. Here's a clinical example, and I'll be quick about this. We're almost done. This is a patient that came in. Patient presents with dyspnea. COPD uses home O2 at 2 liters. Progressive dyspnea with increased work of breathing despite NEBs and IV steroids. Creatinine is up to 4.8. Baseline is 1.1, so those baselines are very important. What is your baseline? Because we're always looking, to explain what, is this a chronic or an acute condition? COPD is a diagnosis, respiratory distress, renal insufficiency, plan to transfer to ICU for BiPAP, may need mechanical vent, hypotension, creatinine remains above baseline despite fluids, consult renal labs pending. So based on this documentation, we're able to capture, we leave this patient in a COPD. So that first scenario, this is what the coders would be able to capture from that documentation, that the patient had COPD, so they have a history. We don't know if it's an exacerbation, so they didn't state it that way. They're dependent on oxygen, and they're renally insufficient. And that's the first, that patient probably would go to observation described like that. It's a low severity, the expected mortality, so that risk and that outcome, 0.2%. That doesn't really correlate to that patient. The length of stay would be 2.6 days. The weight is how much we would get reimbursed if the patient was an inpatient. It really doesn't meet an inpatient, that COPD patient. But with better documentation, this is a COPD exacerbation. The patient has chronic respiratory failure from his home O2. He's on continuous home O2. And this is acute renal failure. It's not just insufficient, it's failure. Why be insufficient when you can be a failure? That's one of our nurses say that. And we can actually, the second scenario, we go to a medium and we get a few more days, one more day. But the scenario 3 is really, truly the diagnostic story for that patient. We're at the highest level of severity. We have 3.8 days. The risk of mortality really goes up, and it really definitely tells the diagnostic story for that patient. But you set the stage of, and that's some good ED documentation, but some of those could have even the COPD exacerbation, maybe the renal failure. I suspect renal failure in the differentials, that we could have even supported that this patient should have been an inpatient from the beginning. That beginning COPD, dependence on oxygen, renal insufficiency, doesn't buy a bed. Okay, and then we have progression slides like severity progression. We can code those low conditions like hypoxia, respiratory distress, but it doesn't show the acuity and severity of patients. A medium severity of diagnoses for those, better documentation about their respiratory status, such as COPD exacerbation, chronic respiratory failure. Instead of distress, they're chronically in respiratory failure. Or maybe it's acute respiratory failure, see, at the highest. So severity, acuity is very important along the continuum of a diagnosis. These first ones are just symptoms. We can code those symptoms or low severity diagnoses, but naming those completely are better to show that severity. So we're at the end of this. Any feedback that we need to bring or that you didn't hear with this? We're just saying work with the CDSs. They may query you or ask you for more information in the documentation. They're probably not going to query you. They may have conversations, these two, about what could have been there, would have supported more as you all work with the observation patients.
And we get that and communicate back and that. So just as, from an emergency physician standpoint, if the slide you had with the different, the COPD patient, so as you know from seeing physicians and as they know too, you'll see the whole gamut from those who are brevity to a fault in the others.
Mhm.
And that's a condition of habit. And so how do you incentivize someone to change that habit? That's one notion here. So, so you have physicians who are complaining of increasing burnout, realizing that the government keeps coming up with a different way of trying to lessen the revenue given to that physician, whether it's the 10-point element, review the systems, and up to now value-based.
Yes.
And it's this game that we're playing back and forth that is a source of annoyance.
Yes.
If I work an 8-hour shift and I see 30, 35 people in this high acuity, that 30, 35% of people, brevity becomes my mode of operation, and I have to keep moving on. Now, the nocturnist who's admitting the patients, who may have 5 admissions of the 3 nocturnists, we have 15 admissions, let's say, or you would hope that they have the training to be able to, because they understand, we don't understand admissions. Once the patient leaves the ED, I couldn't tell you anything about the nurse staffing, what floor they go to, what kind of services. I don't know observation from inpatient other than the definition there. As far as to be able to predict that. I mean, I can document what, like you say, think in ink, like, it's in front of me, and that's the take home from this is try to be more verbose. You're hurting cats, but do it. That's my job. But my job. But I think that what you're already doing here too, the strength in it is going to be at that because the admitting level. We don't admit. I don't have privileges to admit, so I can't make that inpatient, outpatient, or observation decision. And then to the end of this education, there's more to the hospital-based physicians. You have independent docs, the surgeons, name those groups. Are they getting this education, and under what manner?
It'll be the same as this right now, and we're going to have it recorded. We're hoping to get it mandatory that they all see it.
So that's where your challenge is, the mandatory part. It's like a unfunded mandate. One to death by 1,000 cuts here, and you have to show what's the value of this to you, and there's value to it, but that's the challenge. Is rather than you need to come here and watch this so that the hospital can get more money. No,
to pay wages.
Exactly. Unfortunately, you're dealing with short-sighted individuals. It's just what's in front of them, what's in it for me. But that's outside of the realm of what I get this, and my job is to get feedback and communicate to the docs. Okay, here's Dr. X. You do a great job. Keep this up. Maybe do this. Dr. Y, you know what? Every time you seem to be lacking this, rule out probable. And it's little simple things and start simple and work up. But that's all I got.
And a lot of times we're reluctant to put in, about status for the ED because you are ordering, but you do set the stage for their determination of what, status they will order. So we kind of have to put that in of saying, you set the stage of how that patient looks. And we definitely use your documentation to support that medical necessity part. So we do need that information. So thank you so much for your time and your feedback. And we definitely will be having a meeting with the hospitalists to share because they do make that determination.
And be strong there. I didn't expand on that notion of what's it mean for that. If you increase your length of stay, you increase your FTEs for the nursing, and you decrease your diversion, all the things that impact us at the front door.
Exactly. Even the risk of mortality, we're increasing that with that documentation and that outcome of that patient. So when something does happen, it was it was expected maybe. Instead of 0.2%, it was a 1.2% chance that something wasn't going to turn out so well for that patient. So
good.
Great, thank you.
Contact, this is new for us on the observation status side, so we'll learn together. And
so, in the ED right now, it's become this recurring theme that keeps coming back to me. It's been a narrative. I've been doing this for a couple of years now, and when I first started a job, one of the first meetings I had was at that time President Mick Gibbs, and the narratives with the ED doc, you admit too many. people.
Oh, okay. But you
And,
don't admit at all, right?
but yeah, that's right.
Right. Okay, I was like,
Yeah,
wait.
yeah.
But I do, if you look at the variability, we'll have a doc who has, admits 20% of the people he sees in the doc, I'm almost up to 50%.
Mhm.
Okay.
Well, again, he does admit, he consults, but the hospitalists now, they don't want to assume that risk of discharge, and so they generally, they will hospitalize. We used the word hospitalize everything.
Yeah.
And so there is some variability, but again, that variability has to do with individual providers' intuition, gut feeling, horror stories,
Yeah.
lawsuits prior,
Yeah.
and external measures, external means of trying to train that out of someone is difficult at best. It's more being aware. Here's how you compare to your peers.
Mhm.
Is there something you can look into to see, about those soft consults? But what I'm trying to get out is that we do not hospitalize admit.
Exactly.
We
Yeah.
consult, and if you want to send the patient home, God bless you,
Yeah,
but
exactly.
put a note in the chart.
Yeah,
Exactly.
document it in the chart.
That's the drumbeat I'm going for.
Yes,
About.
and that's why we're starting this formal process, so we can keep that data and we can have a formal process of looking at that
Yeah.
and seeing, outliers and, and sometimes those providers have to have that conversation one-on-one about, this wasn't supported or this was supported and it should have been different or,
Hospital's going in a really good positive direction right now, and it's kind of ramped up now with the Deepak and Kokura. We've got some more positions in positions that hadn't been filled to help drive this, and it's data-driven, and not to weaponize it, and that's really
No.
important. It's really important to know.
Yeah, not to weaponize
what the big picture is and why
It's
it's
for everybody's
Yeah.
sake, the profile of the physician, you're compared to peers and you're compared to, all the time, you're being compared and,
Right.
and, the outside world's comparing you with health grades and, the public can get onto the internet now and look at those health grade scores and publicly reported stuff like CMS.
Yeah.
And so those outcomes are definitely reported.
Yeah.
So you want to have, usually when they're inaccurate, it's because the documentation is not there.
Yeah.
And that's what we want to make sure that documentation gets there and everything is in place.
Yeah. Not hard, just
Yep.
takes
It just takes time to get there, yes.
consciousness of
And
it.
nagging.
Yeah.
And digging and nagging, yes. Thank you so much for your time,
Pleasure
Doctor.
meeting you all, and thank you.
It was nice to meet you. Thanks for coming out. We'll be in
And you know where to
contact.
find me.
I do.
so,
I
yeah.
found your office.
Great place.
We were right next door yesterday. I'm like, is he here? No, he's not here today.
So you probably see a lot of them in the future, huh?
Pleasure.
Nice
Thank you
meeting
so
you.
much.
Thank you very much.
Well presented, too. so
Okay,
thank
thank you very much.